So Millennium Development Goal 5 asks us to improve maternal health, improve access to family planning, antenatal care, and skilled birth attendants. And most importantly, reduce maternal deaths by 3/4 worldwide. And I want to point out to start that this is the development goal on which least progress has been made of any. So I was asked today to talk to you a little bit about the view from 30,000 feet on this problem. And as I thought about that, I thought, wow, 30,000 feet, that's just about the height that you fly over a country, maybe taking your research data out, maybe bringing in policy plans or interventions. And I thought, that view is great, that's important, but it can be kind of misleading too. You also have to have the view from the ground. As an obstetrician and an anthropologist, I sort of focus on the view from the ground. And I think we have a special capacity here at UW-Madison to integrate both of these views, the view from 30,000 feet and the view from the ground. So I'm starting with the view from the ground. My own research looks at how people who care for pregnant and delivering women explain maternal deaths in a place where maternal mortality is extremely high, and that's the Southeast African country of Malawi. So I'm going to start with a case from my fieldwork, from a previous fieldwork visit to Malawi in 2007. Among other research activities when I was there, I would attend the twice-a-month meeting on the OB unit at the city's large public teaching hospital, where we would review all the maternal deaths from the 2 weeks before and try to figure out what happened and how we would prevent future deaths. And this is that hospital. So here's one case, marked in my notes as case number 442. 15-year-old girl who had delivered her first child earlier that day. She was transferred from Ndeka Health Center to our referral hospital, and she was dead on arrival. She had carried with her her health passport. This is a small booklet, I brought mine for a little audiovisual aid here, in which all of one's medical records are kept, and this is your ticket to admission to the public health hospital. So her health passport recorded that she had visited the clinic twice during her pregnancy. Her weight was recorded as normal. No blood pressure was taken at either visit because the health center where she attended had no working blood pressure cuff. She got 1 dose of medications for malaria at about 7 months pregnant, and she was on iron pills for anemia. She came back to the health center in labor at term. This is not that health center, but it's a similar one, and that's the waiting room out there. Health centers are small facilities that typically conduct anywhere from 600 to 4,000 deliveries per year. They have, in general, no other inpatient care, and they have no surgical capability. At the health center, this 15-year-old girl had a normal delivery of a live-born infant, but immediately following the delivery, the mother had 5 seizures in a row. The health center had no drugs to stop seizures. It had no laboratory equipment except HIV tests. It didn't have a blood pressure cuff, and it didn't have a thermometer. So even basic investigations of what might be going wrong were rather difficult. It also didn't have its own ambulance. So the nurse on duty called the one working ambulance that serves 22 health centers in this city of 1.5 million people, and it took 2 hours to arrive, and by that time it was too late. When we reviewed this case, there was no consensus on the cause of death. The nurse at the health center thought, and I have to say I agree with her, that the odds were this was eclampsia, which is a complication of high blood pressure which can cause swelling of the brain and seizures. However, one of the interns pointed out that malaria can also have seizures, and we knew this woman had been treated for malaria. So can meningitis and encephalitis, both of which are fairly common. One obstetrician who I worked with chalked the problem up to teen pregnancy. We didn't see this much in the old days, he said. Some people believe this is a new problem with the advent of so-called democracy. So, with that information, what's the explanation for this girl's death? Malaria, brain swelling caused by high blood pressure, a stroke, the poverty that meant there was no thermometer or a BP cuff at the health center and no ambulance to take her quickly to the hospital, teen pregnancy, or even democracy. How should the team reviewing this case have recorded her death in health statistics? And how should those in charge of making health policy endeavor to prevent more such deaths? So in Malawi, about half of all births occur at home, or with sometimes with traditional birth attendants, and that's the name for women who get called upon in their villages to attend births, some of whom have some training, many of whom have a lot of experience, some of whom have very little experience. Most of the traditional birth attendants are illiterate, and their status under the law is ambiguous and quickly changing. In part for those reasons, more than 3/4 of deaths are never recorded anywhere, and that's all deaths, not just maternal deaths. This death that I just described turns out to be one of them. The records we compiled never made it to the Ministry of Health, and I found out later that our district reported no maternal deaths at all for the year. So that's your ground level view of one case. So now I'll go up to 30,000 feet as requested. I'm going to lay out the current situation, talk about some areas of consensus and controversy, talk about some good news, because there is some important obstacles to be overcome, and then move to 5 major areas of research I think we could do well with here at UW. So Millennium Development Goal 5 seeks to improve maternal health, and the most important indicator that's being tracked is called the Maternal Mortality Ratio. This is the number of deaths, the number of pregnancy-related deaths for every 100,000 live births, and this varies widely around the world. Here's a world map. You can see on here the countries that are in dark blue have the lowest recorded maternal mortality ratios, so fewer than 15 deaths for every 100,000 live births. The countries on the red end of the spectrum have the highest, and the highest recorded on this particular one is 1,575 deaths per 100,000 live births. So well over 1% in that case. The Millennium Development Goal is to drop maternal mortality ratios by 2015 to an average worldwide of 108 per 100,000, from a world average that in 2000 was estimated to be about 430. Disparities around maternal mortality are greater than they are with any other basic epidemiological indicator, and this slide will give you an idea. So this shows both progress and some examples. So Malawi, which is, by the way, not the worst country in the world in terms of maternal mortality, or in terms of anything else, if there are any Malawians in the audience, is on the right. So Malawi's actually gone backwards, as have many of the countries in sub-Saharan Africa between 1990 and 2006, as best as we can tell. Ireland is currently thought to be the safest place in the world to give birth, and its maternal mortality ratio is last recorded was at 4 deaths per 100,000 live births. However, there's considerable uncertainty about the actual numbers of maternal deaths, and the uncertainty ranges are so large that it's actually difficult to detect trends in many nations and not completely clear what the trend is worldwide, although I'll talk a little bit more about that later. We think the trend is positive worldwide. Okay, so what do we know? 97% of maternal deaths roughly occur in these 68 countries. In fact, 80% of maternal deaths occur in 21 countries in Southern Africa and South Asia. Many, but not all of these countries are chronically conflict-torn. In many of them, women are systematically disempowered, and the combination of the two things can be particularly lethal, as we see from the example of Afghanistan, which has the worst maternal mortality in the world. Roughly 60% of maternal deaths happen in Africa, roughly 30% in South Asia, and less than 5% in high-income countries. Another point of consensus, most deaths are preventable. Over 4 out of 5 maternal deaths are caused by hemorrhage, that is bleeding, overwhelming infection, unsafe abortion, obstructed labor, and hypertensive complications of pregnancy. If you have a skilled birth worker who has access to surgical care, a basic set of medications, nothing fancy, and supplies, and blood transfusion, you can prevent nearly all of these deaths. Other areas of consensus? First of all, maternal mortality is not on track to meet Millennium Development Goal 5. That's probably obvious. It's 2011. The goal is at 2015. But that's not only important in its own right, but it's important because maternal mortality is also an indicator of other issues that are important. So for instance, it turns out maternal death is a reasonably good marker of overall health system functioning. If your maternal death rate is high, it indicates that either hospitals and clinics aren't functioning well, or people aren't able to reach them, or in some cases both. Also, maternal death and newborn death track closely. So if you improve maternal safety, that correlates well with newborn survival. Finally, there is, I think, a general consensus that women have a right to birth in a safe facility attended by a skilled health worker, preferably a trained midwife who has surgical backup available. Why a midwife, you might be wondering? Well, although it pains me slightly to say this as an obstetrician, They are cheaper to train and to salary. They are better at following guidelines, and they are less likely to perform procedures and interventions that cause harm. All right, some areas of controversy. Does safe birth include birth at home? Home birth is generally conceded, not universally conceded, to be safe in the developed world, but its role is unclear in the developing world. How much of the problem is iatrogenic? That is, how much of the problem is caused by us, caused by health system workers? Particular areas of interest: the rising rate of cesarean section in many countries around the world, and high rates of hospital or health center acquired infections. Thought to contribute to a lot of maternal death, but it's really unclear how much of a role that plays. And just how much of the problem is related to unsafe abortion. Estimates on this vary wildly. It's thought to be underreported in most places, and you can imagine why that is. In many cases, abortion is not only politically but personally hairy, and if you could attribute a death to something else, you likely would. Okay, there is some good news. There is a developing consensus just in the course of the past year or so that there's been some progress. So it looks like the global maternal mortality ratio has dropped. Oops, that's a little premature. Probably drops in global fertility rates and a rise in women's secondary education are the main drivers of the lower global maternal mortality rate. A recent regression analysis confirmed previous work showing that maternal mortality is very strongly related to total fertility, and fertility is strongly related inversely to women's education. We can be pretty sure that skilled birth attendance has also played a role, delivery with trained midwives and doctors. But it's so closely correlated with income and education that its independent value is actually really hard to pick apart. More good news: a number of countries have had demonstrable success in reducing maternal mortality with a range of approaches. So it looks like there are many different ways to have a really significant impact. And 3 success stories that I won't go into, Bolivia, Bangladesh, and Egypt, have all dropped maternal mortality rates quite substantially, and there are others as well. There are some obstacles to achieving this Millennium Development Goal. We're not going to achieve it by 2015, but there are some obstacles to achieving it at all. The first, an important one, is HIV. So this slide shows you projected maternal deaths from 1980 to 2015. The blue line on there is what we would imagine would have happened without HIV. The red line is the actual result with HIV. So you can see that HIV is responsible for a substantial proportion of maternal deaths. It's estimated it may be as high as 1 in 5. Probably explains some of the disproportional death rate that affects Southern Africa. So I began this with a story of a young, healthy girl who died of a pregnancy complication, but this is actually something of an exception, including in my own notes. Among the cases I collected and the data that's available nationwide in Malawi, it looks like it may be as many as half of the women who die who are known to be HIV positive, and another quarter in which their HIV status is unknown. Given that only about 1 in 8 women in the country is seropositive at reproductive age, it looks like deaths are pretty obviously clustering disproportionately in those who are HIV infected. That means that if we stall progress on treatment of HIV, which has happened to some extent, we're going to slow progress on maternal health as well. So HIV is one obstacle. A second obstacle is gender inequities. Nearly worldwide, women are marginalized in the decision-making processes, and women's reproductive health is disproportionately politicized. Women often don't have the right to decide their own total fertility. They may face restricted access to contraception, and they very often face restricted access to safe abortion. Political commitment and financial commitment both fall short of where they ought to be. And one part of that problem is not just politicization, but competition between various funding programs. So for instance, between community-based and clinic-based approaches, or between maternal health programs and child health programs, which has had a substantial effect, and which brings to mind for me this proverb from Cameroon: when the elephant and the rhino fight, it is the grass that suffers. There's a subtler obstacle to attainment of this Millennium Development Goal, I think, and that is that maternal death really reflects a health systems problem. It's not amenable to a single simple intervention, unless one of you geniuses out there in the room can think of one, in which case all power to you. In my opinion, there's no vaccine or pill that is likely to solve this problem. There's no magic bullet, and there's probably no vast pool of money to be made by entrepreneurs. Instead, the entire system of family planning, antenatal care, reproductive care, obstetrical care has to be addressed. And finally, and I think this may be underrated and an area where we could do some research, data collection problems are really important. Where the problem is worse, the data collection is also the worst. Of all of the countries in sub-Saharan Africa, only South Africa has complete death registration. In other words, death certificates required. Maternal mortality ratios are very often calculated in other ways, and we can talk about those. The sisterhood method would be one, and then generalized to wider populations. So all of these approaches have huge uncertainty ranges, so it's difficult to know the status of the problem in some cases, even if there is a problem, and practically that means it's also really difficult to assess when your interventions are actually working. All right, to kind of finish up here, what's possible for us here at UW? Maternal health is a realm that I think really actually needs an interdisciplinary approach. We need people who see from 30,000 feet, people who see from the ground, and we need them to talk to each other. If we're going to make any difference, we need international partnerships, lots of them, with people who are already working on the problem in the places where it's worst. And we'll need people from UW who are capable of making and sustaining those international partnerships. So here's some areas where I see room for research for us. Counting maternal deaths. Are there innovative ways to count deaths that don't depend on expensive infrastructure, that don't disproportionately obscure certain problems, that don't create a market for falsified statistics? Diagnosing. What exactly is killing women in different places? And here we need to pay attention to both proximate causes and root causes. So if hemorrhage is a major cause of death in one particular place, blood banks are going to be useful. But if gender inequalities are so severe that a woman can't make the decision to go to the hospital when the male head of household is absent, then blood banks alone are probably not going to be enough. There have been some advances in the arena of diagnosing where few deaths happen under medical supervision. Verbal autopsy is one example where people ask a list of structured questions related to the pregnancy designed to get at probable causes of death. And in the US and other places where maternal death is relatively rare, within the past decade, we've expanded our analysis to look at so-called near-miss cases where women almost die. So that gives us a bigger pool of cases to analyze to figure out what's going on. Third area, prevention. How can we prevent pregnancy complications? Fourth area, treating complications when they do occur. The Global Advanced Life Support in Obstetrics course, for instance, was developed here. It's a weekend-length intensive training program that's been used to train 18,000 clinicians in 27 countries, so that's a pretty big deal in how to handle obstetric emergencies. And then last, learning. How can we systematically analyze successes and failures? First of all, identify them, then analyze them. Political successes and failures, institutional successes and failures, medical successes and failures. One last note. Maternal health is worst in Africa and South Asia. At UW, we have among the best African studies and South Asian studies programs in the world. We have a genuine international community. We have undergrads, grad students, nursing students, professional students, and faculty who hail from many of these nations. Admittedly, we need more, but we are off to a good start. We have people who speak and can teach local languages. We have people who understand legal and political structures in the nations where the risk is highest. We have people who know the different ways in which systemic health sector problems and gender disparities can be most successfully addressed. We have people who understand the epidemiology of maternal death and people who know the lived experience of clinicians and patients where maternal death is widespread. I don't know any one person who fits all those criteria, but we're a university that's good at teams, and teams are going to be needed. Thanks.